Hi, I'm Mark Favett. I'm coming to you from Wayne State University in Detroit, where I run the point of care ultrasound programs in the emergency departments, and I also run my own research echocardiography lab through the School of Medicine. Today we're going to talk about fluids and valves using point of care ultrasound in critically ill patients. These are my disclosures. And here is the game plan for today. We're going to spend the first part of the lecture discussing the IVC and some of the pitfalls associated with hanging your hat on the IVC for fluid resuscitation. And we're also going to talk a lot about extravascular lung water and how this might be a more precise way to gauge the tolerance that your individual patient might have to large volume fluid resuscitation. Following that, we're going to talk about valvular catastrophes. We're going to work through the valves, in my opinion, from least severe to most severe when things go wrong with them. And at the end, I'm going to put together a few cases that will hopefully tie all of these concepts together for you. And here's a picture of our friend Goldilocks. And Goldilocks nailed fluid resuscitation decades ago. What we're looking for is not too much, not too little, but just the right amount for your patient. As with most things in clinical medicine, the extreme phenotypes are pretty easy to recognize. We can all detect a patient like this who is extremely volume depleted. Often you get a little clue with a sodium that's through the roof, a BUN that's through the roof. The physical exam has multiple findings that indicate that this patient is way behind on fluids, and we don't really need point of care ultrasound to figure this situation out. Even our friend Goldilocks was not in need of point of care ultrasound to determine that this was too little porridge. The clinical scenario that may be harder to recognize and is probably more deleterious for the patient is the one where they have too much fluid. Here's an article from Critical Care Medicine in 2011 looking at patients in septic shock. And what we learned from this, if I had to choose between this Goldilocks who encountered too much porridge and the Goldilocks who encountered too little porridge, I think I'd rather be the too little porridge Goldilocks than this raging inferno. So before I can sell you on the evaluation of extravascular lung water as a preferred modality to guide fluid resuscitation, I probably need to tell you why the IVC is not the preferred modality. These two papers here are the original papers in critical care medicine from the mid-2000s that looked at the respiratory variation in the inferior vena cava and its relationship to intravascular volume status, central venous pressure, and fluid responsiveness in critically ill patients. One thing that's important to note from these studies is that all of these patients were intubated and all of the assessments were done by intensivists using transesophageal echocardiography. If you are going to use the IVC to help you make decisions, and I'm not here to tell you that you should never use it, but if you are going to use it, you should probably understand the difference between distensibility and collapsibility. A distensibility index is looking at the difference in inspiratory and expiratory diameter. We use it in intubated patients. And a distensibility index that's greater than 12% in a steady state intubated patient suggests that they're going to increase their stroke volume with a fluid bolus. In spontaneously breathing patients, we use the term collapsibility. Collapsibility is the change between expiratory diameter and inspiratory diameter in someone who's spontaneously breathing, who's creating negative pressure in their thorax during inspiration. Here, a collapsibility index that's greater than 40% suggests that you have a patient in front of you who will, again, respond to a fluid bolus by increasing their stroke volume by 10%. If you are going to use the IVC as part of your assessment for fluid resuscitation. A neat way to do so is utilizing M mode. Using M mode gives you all of the information of the diameter of the vessel in both inspiration and expiration on a same screen with a frozen image, making the calculations much less time consuming and easier to perform. However, there are some pitfalls with M mode. The primary one is demonstrated here. Patients in shock often have increased respiratory effort and accessory muscle use. And what happens here is that the plane of the beam and the plane of the IVC are no longer lined up, which creates the artifact of increased collapsibility, when in reality, all that happened was the IVC moved out of the plane of the imaging beam. So IVC can be nice, but I find that it's really only nice at the extreme ends of the hypovolemic or volume overloaded continuum. Other pitfalls include the fact that you're looking at a structure that feeds into the right atrium, and what you're really interested in is knowing what the preload situation is in the left ventricle. And there are a ton of cardiac anatomy structures between where you're looking and where you're interested in. Using lung ultrasound, you don't have any of these anatomic limitations. What you're looking at is an artifact of what you're looking at. With lung ultrasound, what we're asking is whether these lungs are wet or dry. Here we're looking at a picture of dry lungs. These are A-lines. A-lines are an artifact when air interfaces with air in the plane of the imaging beam. If dry lungs have A-lines and a horizontal reverberation artifact, then wet lungs have the opposite artifact. It's called B-lines, and it's a vertical interface, which sometimes is known as a comet tail artifact or a lung rocket. This is an artifact that's due to the interaction of air with fluid at the alveolar interstitial membrane, which is located in the near field with this hyperechoic horizontal white line. And here we're looking at B-lines, which are a vertical artifact that occurs when air interfaces with fluid in the plane of the imaging beam. I really can't make it any more basic than this when it comes to interpreting the extravascular lung water. A predominant A-line pattern means you're looking at a patient who has low to normal left atrial pressures, dry lungs, and they are going to be fluid tolerant. A B-line pattern means you're looking at a patient who has wet lungs. Sometimes this is referred to as the alveolar interstitial syndrome. And this patient has pulmonary edema. Sometimes it can be frank pulmonary edema, which is quite detectable on physical examination. But oftentimes, this pulmonary edema exists in a preclinical state that can be very difficult to detect, both with traditional physical exam and very difficult to detect with plain chest radiography. This is the part of the lecture where I'm going to spend a few slides trashing chest radiography as an adequate means to detect pulmonary edema. This is a systematic review and meta-analysis that was done in academic emergency medicine, looking at the diagnosis of acute cardiogenic pulmonary edema utilizing ultrasound of the lungs. And here we see the performance characteristics, which are pretty stunning. If you're familiar with likelihood ratios, a positive likelihood ratio that's greater than 10 is generally considered to be a diagnostic test. And a negative likelihood ratio less than 0.1 is generally considered to be a good test to rule out a condition. Other tests with a negative likelihood ratio in this ballpark would include CT of the thorax for pulmonary embolism and CT of the abdomen and pelvis for appendicitis. These investigators here utilized a thermodilution POCUS system to calculate the volume of extravascular lung water in a group of critically ill patients. They then performed thoracic ultrasound and calculated something that's called a COMET score. The higher your COMET score, the more B-lines you have. The more B-lines you have, the more wet your lungs are. And you can see this line of fit is pretty good and demonstrates that when we actually measure extravascular lung water, there is significant correlation with the findings on point-of-care ultrasound. In case you weren't convinced the first time I said it, extravascular lung water is very bad for your patient. Saka et al. In Chest in 2002 looked at a mixed cohort in a mixed use medical and surgical ICU of patients with septic shock, ARDS, intracranial hemorrhage, and hemorrhagic shock. They measured extravascular lung water utilizing a transpulmonary thermodilution technique. And what they found, predictably, is that non-survivors had a greater magnitude of extravascular lung water than survivors. Like the investigators from earlier in the lecture, they also divided the patients into quartiles based on the quantity of extravascular lung water. And with each progressive increase in extravascular lung water, mortality increased as well. This mortality increase related to extravascular lung water was particularly true for two of the diagnoses that they studied: severe sepsis and septic shock, as well as ARDS. Harkening back to our old friend Hippocrates, he said that the first thing we should do is to do no harm. And with these critically ill patients, the easiest way to harm them is to give them more volume that's just going to simply end up in their lungs when they're already in a volume overloaded state with increased extravascular lung water. Here are two examples of patients with increased extravascular lung water. The patient on the right has a much greater degree of extravascular lung water than the patient on the left does. The B lines are confluent and basically converge upon one another in the far field, whereas the patient on the right has more of a linear spread with some separation of the individual B lines in the far field. Here's a quick case of a patient I saw on New Year's Day 2 years ago who extravascular lung water proved to be a potent predictor of in-hospital morbidity. This was a demented man, pleasant with his wife, there with what seemed to be a run-of-the-mill flu or pneumonia. Radiology gave us the old hedgy sort of read with this chest x-ray. The flu swabs were negative, so we admitted him to the hospital, started treatment for pneumonia, and I moved on with my day. However, the patient's primary care doctor, when I called to admit him, did say one thing that was going to portend a very bad outcome. She told me over the phone that this was the nicest patient in her entire practice, which I think encompasses over 5,000 patients. And I knew right then that something terrible was about to happen to this man today. I just didn't know what. About 6 hours after that conversation, the man finally had a room assigned on the medical floor when I was paged in a panic-stricken voice overhead to go to his room. There, we found the man completely obtunded, tachypnic, and with a beautiful waveform on his pulse oximeter, saturating at 14%. This is what his lung ultrasound looked like. Here are two clips of his heart, which basically show a hyperdynamic left ventricle just banging away, hanging on for dear life. Here's his IVC. If we were to look at this information in isolation, we might feel compelled to give this person more fluid, which would only cause further harm to his already flooded lungs, as his ARDS-like state has begun to evolve in a fulminant fashion now. At this point in time, there's simply nothing left to do to support this person other than to intubate him, start him on mechanical ventilation with positive pressure, and utilize a lung projective strategy as you treat his underlying septic focus and basically play the waiting game. Ultimately, after 5 days on the ventilator and a week and a half in the hospital, the man was discharged home with his wife. Here we see a curve that's called the Merrick-Phillips curve, superimposed on the Frank-Starling curve, which is the lower right-hand curve. What we see here is that as patients become less fluid responsive, extravascular lung water and resultant tissue edema increases markedly because of increased cardiac filling pressures and transmitted hydrostatic forces. This happens in a couple of situations, all of which cause endothelial damage, namely sepsis, ARDS, and also pancreatitis in burn patients. Again, extravascular lung water is a potent predictor of death. So to wrap up the fluid resuscitation part of this discussion, I really like this strategy utilized by Lee et al. who's part of the Arntfield group at the University of Western Ontario. Here they recommend for a combination of lung ultrasound and IVC. They start with an IVC assessment, and again, they're looking for the extremes of the phenotypes. Distended or underfilled? Are they extremely hypovolemic or are they extremely overloaded? Often the IVC in isolation can provide us with this information. An IVC that has kissing walls or an IVC that's completely plethoric generally tells you where your patient is in the fluid spectrum. But anything other than those two situations, I would very strongly advocate for the use of lung ultrasound to figure out whether or not your patient is even tolerant to fluids. Patients who have high quantities of extravascular lung water are not tolerant of fluids, and giving them fluids is only going to serve to increase their mortality. I promise you that if you utilize this strategy in your next critically ill patient, you're going to increase the chances that Goldilocks finds the amount of porridge that is just right. Now we're going to shift gears a little bit and talk about something that requires a little more skill from an image acquisition standpoint, and that's looking at the cardiac valves in our critically ill patients and trying to identify catastrophic etiologies that explain the patient's shock state, which will then facilitate expedited management. Here we're looking at the surgeon's view of the heart, which has all four valves. Important things to note are the locations anatomically of the valves. The top of the screen is anterior and the bottom of the screen is posterior. You see the anterior most valve is actually the aortic valve, which renders it more susceptible to traumatic injuries and blunt cardiac trauma. You'll also see that the two valves with the largest surface area are the tricuspid valve on the bottom right and the mitral valve on the bottom left. In these next few slides, we're going to work through the different echocardiography views and identify which valves can be seen on which of the views. Here in our parasternal long axis view, we get a really good look at the left-sided valves, the mitral valve and the aortic valve. In this view, we're really looking for big stuff. The big stuff that we can see would be things like a papillary muscle rupture or an aortic dissection that starts in the aortic root or that causes wide open aortic insufficiency. Both things which will most likely lead to the imminent demise of your patient if they are not recognized promptly. An adjunct view that we can utilize from the same parasternal long axis window is called the RV inflow view. We'll practice this while we're scanning today, but this view can be obtained by starting in your traditional parasternal long axis position and fanning the probe to point towards the right iliac crest. Once we do this, we're going to have a view that looks something like you should see on the screen. The valve in the center is the tricuspid valve, and here we can see the anterior leaflet in the near field, and typically the posterior leaflet in the far field, although sometimes it's the septal leaflet. The difference would be known by whether or not you can see the LV cavity in the field. If you can see the LV cavity in the field, you're looking at the septal leaflet. If you fanned it and angled in such a fashion that you no longer see the LV cavity, you're looking at the posterior leaflet. The short axis imaging from the parasternal position is essentially cross-sectional imaging of the heart. Here we have 4 different planes that we can slice through the heart. A, B, C, and D, starting on top right and working in a clockwise fashion to the bottom left. The parasternal short axis imaging window directed towards the base of the heart gives you 3 different valves. The center valve is the aortic valve. Here we want to pay close attention to the number of leaflets. Patients who have bicuspid aortic valves are at a substantially increased risk for aortic valve stenosis as well as aortic dissection and other aortic syndromes. The pulmonic view is immediately adjacent to the aortic valve in about the 2 o'clock position relative to the aortic annulus. This valve is just simply a typical innocent bystander in valvular pathology. The tricuspid valve is at the 10 o'clock position of the aortic annulus. This often gives you a better Doppler window than the RV inflow does to look at pulmonary artery pressures. Fanning the probe just slightly towards the patient's left flank will give you a view of the mitral valve in a cross section. This is typically described as a fish mouth-like appearance. This can be an excellent view to look for mitral valve vegetations in infective endocarditis. My personal favorite view in echocardiography is the apical 4-chamber view. This gives us the best direct comparison of the hemodynamics of the right side relative to the left side of the heart. It also gives us great Doppler interrogation opportunities at the AV valves, namely the tricuspid valve and the mitral valve. And in this view, we will be most likely to recognize mitral valve regurgitation, which often is the only finding on point-of-care ultrasound that will tip us off that a patient has infective endocarditis of their mitral valve, because the posterior location of the mitral valve renders it quite difficult to get the necessary spatial resolution to identify vegetations on the leaflets, and often transesophageal echocardiography is needed to identify definitively lesions on the mitral valve. From the apical 4-chamber view, simply fanning the probe so that you're pointing at the sternal notch will give you what's called the 5th chamber. The 5th chamber is not actually a cardiac chamber, but it's the aortic valve and the left ventricular outflow tract. This is the best window to do Doppler interrogation of the aortic valve to identify the aortic insufficiency that is killing your patient who's dying of an aortic dissection. A view that is often wildly underutilized in point-of-care echocardiography is the apical 2-chamber view. This view can be achieved from the 4-chamber position simply by rotating the probe approximately 90 degrees counterclockwise so that the indicator lines up with the distal clavicle. This view is really helpful for 2 reasons. It gives you a second, more cross-sectional imaging plane of the mitral valve, and it also gives you an unrivaled view of both the anterior wall and the inferior wall of the heart. The anterior wall is on the right side of the screen on the indicator side, and the inferior wall is on the left side of the screen on the non-indicator side. A 4th imaging plane from the apical position can be obtained by continuing to rotate your probe counterclockwise so that the indicator now points to the right shoulder. This should look a lot like a parasternal long axis view to you, but simply rotated 90 degrees, so we're looking at it from a vertical rather than a horizontal plane. This view can be very helpful to interrogate the aortic valve and the left ventricular outflow tract. Last, and probably least, is the subcostal or the subxiphoid view. This is a really good overview of all 4 chambers of the heart. It often doesn't provide you a lot of specifics in terms of valvular pathologies, however. I've chosen to order my valve pathology slides based on the order that I would choose to have my valves fail if someone held a gun to my head and said I had to choose one cardiac valve to fail. I've excluded the pulmonic valve because there are very few specific pathologies that I would expect anyone at the point of care to be able to recognize. It's usually an innocent bystander, as is the tricuspid valve, so that's why I've chosen it first. It has a very large surface area. It's actually the largest of all of the valves. Typically, the primary pathology we're going to see with the tricuspid valve is endocarditis. Here's an example of tricuspid valve endocarditis in a parasternal short axis view. At the beginning of the clip, you can see a large vegetation that's mobile, that's emanating from the tricuspid valve. This is not a subtle finding, and this is a vegetation that was seen from multiple views on this particular patient. This is another patient with tricuspid valve endocarditis. However, the size of this vegetation was much smaller than the previous patient, and the first tip-off that there was something wrong with this tricuspid valve was the high-velocity, eccentrically directed regurgitation jet that was detected in the RV inflow view. There's a lot going on in this subcostal view, but this is another patient with tricuspid valve endocarditis. There's also a small, hemodynamically inconsequential pericardial effusion that's best seen in the anterior field. This is another patient with tricuspid valve endocarditis. It seems like this is pretty common in Detroit. This sonographer chose to utilize an apical 4-chamber view with an RV-focused approach, meaning that they tilted the probe towards the patient's right and fanned it slightly anterior to bring the RV into a greater focus. And here we see a very linear hyperechoic structure that emanates from the tricuspid valve, and it's an endocarditis vegetation. The next two patients do not have tricuspid valve endocarditis. They have pulmonary hypertension, and they have tricuspid valve regurgitation as a result of the increased pulmonary vascular resistance. This is usually detectable in multiple echocardiography windows, but the apical 4-chamber view, because the sound beam and the Doppler beam is parallel to the direction of flow through the valve, gives you the most accurate information. This patient here actually has a pulmonary artery pressure that is slightly higher than her systolic blood pressure. She was seen in the ED because her PICC line fell out, the PICC line that she was getting Remodulin through. And within 20 minutes of the PICC line falling out, she started to become dyspneic and hypoxic. Clues that this is a chronic and not an acute problem are the thick-walled trabeculations of the right ventricle, the size of the right atrium, and the small size of the left atrium. And for those that are wondering, the pulmonary artery pressure in this patient was calculated by measuring the peak velocity of the tricuspid valve regurgitation jet, taking that number and squaring it, and then multiplying it by 4, which is an application of the simplified Bernoulli equation, which is what we use to calculate pulmonary artery pressure. The next valve that I would choose if the tricuspid valve was taken off the table and I was left with the mitral valve or the aortic valve to fail would be the mitral valve. The trouble with the mitral valve is that it is very difficult to detect specific pathologies with transthoracic echocardiography. And often we're only seeing clues about the abnormalities and that the patients need to go on for TEE for a more definitive diagnosis. When I review images in QPath of our residents and other physicians doing echocardiography, I see no shortage of masses on the mitral valve. However, most of them turn out to be benign. Here's an example of a benign mass in the mitral valve. You should see a rounded, circular, hyperechoic, otherwise white, lesion located at the lateral annulus of the mitral valve. This is calcification of the mitral valve annulus. It's something that is extremely common in renal failure, and thus it is something that is exceedingly common in Detroit. This is an exceedingly difficult echocardiogram to interpret. This patient also has calcified mitral valve annulus with a similar rounded hyperechoic lesion at the lateral annulus of the mitral valve. But if you look closely, from that point, working back towards the left atrium, there's a much smaller, much less hyperechoic lesion that's actually mobile, and that is the vegetation that's coming from the lateral annulus of the mitral valve. If the last one was exceedingly difficult, this one is an even greater degree of magnitude more difficult. This one fooled me. This is a patient who also has mitral valve annular calcification, and they look like they also have something working back towards the left atrium from that same lateral annulus. I suspected that this was endocarditis in a patient with renal failure. However, the patient underwent a TEE on the second day of hospitalization, and all of this turned out to be mitral annular calcification. Remember, as a point-of-care provider on the front lines in the hyperacute setting, it isn't always your job to make a specific diagnosis, but it is your job to recognize abnormalities and to know when things are not normal and need to be referred for further testing. This is the color Doppler image of the patient from the previous slide. You'll see an eccentrically directed regurgitant jet. And this is what tipped me off that I thought that this was mitral valve endocarditis and not simply mitral annular calcification, because it's highly unusual for calcification in and of itself to cause regurgitation. Stenosis can happen as a result of advanced mitral valve annular calcification, and often these cases are amenable to balloon valvulotomy. However, this patient's case was very atypical. We will talk more about the significance of eccentric versus central mitral regurgitation jets in a few slides. Just to simplify things at this point, a central mitral valve regurgitation jet is most likely due to a hemodynamic problem affecting the LV and not a problem of the valve itself, whereas an eccentrically directed or wall-hugging jet typically signifies primary valve pathology. As hard as native mitral valves can be, replaced bioprosthetic mitral valves are even harder. This is a parasternal long axis view of a bioprosthetic mitral valve. The motion of the mitral valve should look significantly different to you than the previous slides, or probably from most of the mitral valves that you've seen in your care over the years. This is a color Doppler image of this patient's mitral valve in a parasternal long axis plane. And while parasternal long axis windows are not the best to detect mitral regurgitation, there's no evidence of any mitral regurgitation here, which should begin to make you think that this might be a normally functioning bioprosthetic valve. But as with x-rays, one view in echocardiography is no views. So let's see if we can get some more views of this valve. Well, it's a good thing we got more views. This is an excellent apical four-chamber image of the same patient. And you can very clearly see an ovoid hypoechoic mass that's mobile and adherent to the bioprosthetic valve leaflets that flops back and forth in and out of the left atrium during movement of the mitral valve. So this patient has mitral valve endocarditis of their bioprosthetic valve. This is a catastrophe waiting to happen. These patients have a high rate of an annular ring abscess and concomitant involvement of the aortic valve root because there is a structure called the aortomitral curtain that was compromised when this mitral valve replacement surgery was performed. And so when this infection really starts to set in, things can get bad very, very fast. This is also a non-native mitral valve, but this is a mechanical valve. This is a parasternal long axis image in a patient with a cardiomyopathy. This is a normally functioning valve. What you should notice are pretty intense reverberation artifacts, similar to the type of reverberations you see when you're imaging the lungs. Probably the most important pearl I can leave you regarding the mechanical mitral valve is that it should never leak. A mechanical mitral valve that has any regurgitation, any whatsoever, should be considered to be endocarditis until proven otherwise. This is a case I'll never forget from my fellowship. This was a patient who started out in our fast track urgent care area because she mentioned the phrase vaginal discharge to somebody in triage. So she was initially triaged to the low acuity area. Eventually, she admitted to weeks of abdominal pain, both flanks, as well as occasional fevers. She eventually found herself in the CT scanner, where she was noted to have bilateral renal infarcts. So at that point, a cardioembolic source was suspected. So I was put on the case during the second or third month of my fellowship. And here is a parasternal short axis view of her mitral valve with an extremely, extremely large goober dancing around off the anterior mitral leaflet. Remember, when we look at the mitral valve, specific pathologies are not often what we're looking for. We're looking for corroborating evidence that the abnormality we've seen is hemodynamically consequential. And here we have it. This is a parasternal long axis image of this patient's mitral valve with an eccentrically directed mitral jet. Here is a measurement of the mass. 2.8 centimeters is an enormous size for something to be attached to the mitral valve. After identifying this, I basically sprained my wrist from patting myself on the back so aggressively for the next couple of days. However, despite this patient successfully undergoing a mitral valve replacement surgery, she actually died from suicide 2 months after being discharged from the hospital. Here's a somewhat common mitral valve pathology that very rarely progresses to something life-threatening. This is prolapse of the posterior mitral leaflet. And here, courtesy of Wikidoc, is the classic M-mode image of the posterior leaflet mitral valve prolapse, which you can see in the middle of the M-mode tracing between the A wave and the E wave. This is an extremely elderly patient who presented with progressive exertional dyspnea over the course of months. Here you see a heavily calcified mitral valve with severely restricted mobility of the leaflets. The color Doppler images are particularly instructive because they demonstrate a combination of regurgitation and stenosis. If you look at the color bar on the top left of the screen, you'll see that the yellow colors represent high velocity anterograde flow, and the turquoise colors represent high velocity retrograde flow. The flow through the stenotic valve, whether it's anterograde or retrograde, is extremely high velocity, pretending that there is an extremely small surface area through which flow is occurring. This is an apical 4-chamber image of the same patient. And here is an apical 4-chamber image with color Doppler. Given the advanced age of the patient and the family were not interested in undergoing any invasive surgical measures. So they took the patient for a balloon valvulotomy, where basically they inflate the balloon in the mitral valve annulus and try to crack the commissures open from all the calcification in order to improve the cross-sectional area of the valve. This is more of a palliative type procedure that is probably going to need to be redone in the next year. The next couple of slides are going to show you several images of patients with mitral valve regurgitation. This is a commonly misunderstood entity in people who are starting out with point-of-care echocardiography. The biggest point that I can make is that when the jet is eccentrically directed in the left atrium, typically there's a problem with the valve itself. When the jet is centrally directed into the left atrium, the problem is in the left ventricular hemodynamics, and fixing or replacing the valve isn't going to actually do anything for the patient. Here's an example of an extremely high velocity wall hugging jet, indicating that there is a problem with the valve itself. This patient actually has multiple regurgitant jets, which again indicate that the problem lies with the valve itself and not with the left ventricular hemodynamics. And this patient probably needs a mitral valve repair or replacement. And TEE would be very helpful to identify which of the scallops might be involved. If it's a single scallop that's involved, this patient would be most benefited from a mitral valve repair at a surgical center with expertise. If there's multiple scallops involved, repair could prove to be too technically challenging, and replacement might be the best measure. So in this example, we're going to use what's happening in and around the mitral valve to maybe help us clue in to an extremely rare but lethal diagnosis. Here we see calcification, restricted mobility, and hyperechoic tissue surrounding the valves. We also see the left ventricle, both septal wall and posterior wall, are extremely thickened, and the myocardium does look more hyperechoic than usual. Here's a more extreme example of the same diagnosis in an apical 4-chamber view. What if I told you that this patient had renal failure as well? Would you be able to guess the diagnosis? The diagnosis is the same diagnosis that afflicted this man who ran my Detroit Lions franchise into the ground from 2000 to 2007. In case you're not aware, Matt Millen, the former GM of the Lions, was diagnosed with cardiac amyloidosis and developed stage D refractory heart failure over the last year. However, he was the successful recipient of a cardiac transplant around the turn of the year in December. And word is he's actually doing quite well. Here's one last mitral valve to look at. I want you to pay close attention to the anterior leaflet, the one that's closest to the left ventricular outflow tract. It sort of takes on a funny shape during diastole. What is it? No, Wayne Gretzky does not have rheumatic mitral stenosis, but Wayne Gretzky's a hockey player, and the shape of the mitral valve anterior leaflet that I was trying to call your attention to looks like a hockey stick, and that doming, curved hockey stick appearance is pathognomonic for rheumatic mitral valve stenosis. And the last valve I would ever choose to go bad in my own heart would be the aortic valve. The aortic valve is really complicated. It has 3 cusps, at least when it's anatomically normal. 2 of those 3 cusps have the origins of the coronary arteries. And the aortic valve is basically the last line of defense before the systemic circulation. Any problems with the aortic valve tend to cause upstream problems on the rest of the valves and significant downstream problems for the aorta and for the key organs that it perfuses. Here's an example of the upstream problems that can be caused by aortic valve dysfunction. This patient has significant aortic valve regurgitation, which is impacting the mitral valve and causing diastolic mitral regurgitation. In this patient, fixing this mitral valve will do nothing to help the patient, as the problem lies with the aortic valve. Here's a color flow Doppler image of an apical 5-chamber view, and here it's really important to pay attention to the direction of the regurgitation. Unlike the valves we've looked at previously, when the aortic valve regurgitates, it's going to come back towards the probe. So the color is going to be on the red, orange, and yellow side of the scale, as opposed to the blue and turquoise colors we've been seeing previously. In case I haven't mentioned it to this point, the overwhelming majority of the images you've seen in this lecture have been from residents in our emergency department. Here is a resident who dutifully followed my instructions that they should make the color Doppler box as small as possible in order to maximize the resolution of the two-dimensional pictures. However, this particular resident may have taken the message a tad too far, as we can only see a little sliver of an aortic insufficiency jet, and we're not really actually getting the full picture of what's happening with the hemodynamics of this aortic valve regurgitation and whether it's mild, moderate, or severe. Same patient as before. This is an apical long axis, sometimes referred to as an apical 3-chamber view, which can be achieved simply by rotating your probe so that the indicator now points to the right shoulder, similar to a parasternal long axis turned on its vertical edge. Here, the color box is still too small, which prevents us from appreciating the full spectrum of the amount of regurgitation and maybe even the velocity and how much of the retrograde chamber, in this case the left ventricle, is occupied by the regurgitant jet. Here's a parasternal long axis image of a patient with aortic valve regurgitation. This is a really quality image. The problem is, with the parasternal imaging window, it's very easy to underestimate the degree of regurgitation from the aortic valve, simply because the direction of flow through the LVOT and aortic valve is essentially perpendicular to the direction of the ultrasound beam. And if we understand our Doppler equation, the greater the angle between the flow and the beam, the less we're going to be able to measure the degree of flow. We're going to underestimate the amount of regurgitation or flow when we have perpendicular or near perpendicular Doppler angles. Here's a patient with a disaster of a diagnosis, aortic valve endocarditis. Here, in a parasternal long axis image, you should be able to see a small, ovoid, hyperechoic mass that's actually attached to the right coronary cusp. The right coronary cusp is the coronary cusp of the aortic valve that is closest to the right ventricle in the near field. The other cusp that you can see in this image is called the non-coronary cusp, and that's the one that's closest to the left atrium in the far field. This is that same patient with a zoomed-in view of the aortic valve utilizing color flow Doppler. This is some really excellent imaging technique used by this resident on this particular case. Again, the problem with the parasternal long axis view of the aortic valve is that we're really underrepresenting the degree of regurgitation. This patient ended up having essentially wide open aortic insufficiency and died shortly after this. This is an apical 5-chamber view of a patient with aortic valve endocarditis. This is a really excellent image where you can see a small rectangular hyperechoic density on the ventricular side of the leaflet. And unlike the previous patient, here we have an apical 5-chamber with color Doppler, so we have an actual accurate representation of the amount of regurgitation from this aortic valve, and there's basically none. This patient actually did quite well. The degree of destruction of the aortic valve from the vegetation correlates directly with the degree of insufficiency. So while this person had a more obvious and much larger vegetation that we saw on the two-dimensional images, they did just fine because the hemodynamic impact of that vegetation on the valve was much less than in the previous patient. Here's another case that concludes with a visit to the Grim Reaper. This was a patient who was brought into resuscitation bay for concerns over stroke related to left-sided hemiparesis and altered mental status. The first clue that this might not be a stroke was in the vital signs. This patient is not hypertensive, and in fact, they look like they're in respiratory failure, hypoxic on a non-rebreather, tachycardic, and tachypnic. They were put onto the acute stroke pathway, sent immediately for CTs, both CT without contrast, CTA, and perfusion. So that's a significant amount of time over in radiology. By the time they made it back into the department, the patient had deteriorated further and required intubation. Shortly after they intubated the patient, because the patient looked to be in shock, they did this echocardiogram right here. And shortly after this echocardiogram, the patient was sent to the neuroendovascular suite for a clot retrieval procedure because the CTA showed an occlusion of the proximal MCA. Looking at this image a little more closely, we can see that there's a large vegetation flapping back and forth through the aortic valve annulus. So large, in fact, it's difficult to identify which annulus it actually originates from. This patient had wide open aortic insufficiency, and after the clot retrieval procedure was performed, basically coded and died on the table in the neuroendovascular suite. This patient has another aortic catastrophe. Only here the aortic valve is an innocent bystander. This is a proximal aortic root aneurysm that we can see on a parasternal long axis image. This aneurysm is so large it actually starts to distort some of the chamber anatomy as the right ventricle looks exceedingly small and sort of out of position because of the ballooned up proximal aortic root. Here with color Doppler in the parasternal long axis window, we can see that there is some aortic regurgitation. However, I hope I've made it clear to you that the degree of regurgitation through the aortic valve seen in the parasternal long axis window is insufficient to rule out severe AI. This is a nice use of M-mode to measure the maximal size of the aortic root, which in this particular patient is 6 centimeters. This patient successfully underwent aortic replacement surgery. So occasionally some of the patients in my lectures do make it, and this is another one that made it. This patient presented to the ED with postcoital chest pain radiating to his back. He had an ultrasound probe on his chest within about 10 minutes of arrival. And shortly after putting the probe on his chest, we identified this flap in the descending thoracic aorta just behind the left atrium on a parasternal long axis image. We had this patient on esmolol and nicardipine before he even went through the CT scanner. And he had an excellent outcome after surgery for a type A aortic dissection. And now we're going to wrap up this lecture with everybody's favorite part of school. It's time for the test. I'm going to present a series of cases to you. And for each individual case, you have to choose one of 3 options. You can either fluid resuscitate the patient, you can fluid test the patient with a small bolus, or we can do a fluid restriction strategy. You can only choose one, and please choose the answer that you think fits best. Again, all of these patients are in shock and none of them are intubated. Here is case 1. This patient has a blood pressure of 80, a heart rate of 75, and they presented short of breath. If you chose to fluid restrict this patient, you would be right. This patient has extremely high filling pressures in their right atrium, as evidenced by their plethoric IVC, which actually measured 3.1 centimeters. If I were taking care of this patient, I would instruct the nurse after placing an IV to KVO the fluids. I would then look at the lungs to assess the degree of extravascular lung water. And following that, I would look at the heart to see if the left or the right side, or even the pericardium, might be the etiology of this patient's extremely high right-sided pressures. So when we looked at the heart, here's what we saw with this case. This is a parasternal long axis view. There's a small pericardial hemodynamically inconsequential effusion. The money here is in one of the valves. Here's an apical 4-chamber view, which should provide you with the diagnosis. This is a color Doppler image of the same patient in an apical 2-chamber view. And here we see high velocity, wide open mitral insufficiency. What if I told you that this patient had been hospitalized 7 days prior for an MI? This patient has a papillary muscle rupture, and this patient needs expedited transfer to an operating room with a cardiothoracic surgeon. Here's case number 2. Again, this patient is in shock. The IVC image is on the left. A representative image of the lungs is on the right. Bear in mind, all of the lung fields looked like this one. So what would you do? If you said fluid test, that is the best answer. Although fluid resuscitate would also be an option. The key finding here is that the lungs are dry. Giving this patient fluid is very unlikely to cause them harm. The issue here is that the IVC is indeterminate. You basically have a free shot at this patient because their lungs are so dry. If their IVC was collapsible, the only answer here would be to fluid resuscitate. But because it's indeterminate, I would accept that if somebody thought this IVC was trending more on the plethoric side, they might be a little more cautious with the fluids and choose to test. So I think the best answer is to test. What if I told you that this was the patient's heart from case 2? What are we seeing here? This is a patient who has right ventricular failure. They have a McConnell sign. This patient has extremely high pulmonary vascular resistance. And in fact, they have a thrombus that we can see through the tricuspid valve in the right atrium. Going back to the question, we definitely don't want to fluid resuscitate this patient. We could still get away with testing, although it's likely the patient would fail the test, and we would eventually find ourselves on a fluid restriction pathway. Here's case number 3. IVC on the left, representative image of the lungs on the right. What would you do? Fluid resuscitate, fluid test, or fluid restrict? There is only one answer here, and it's to fluid restrict. This patient most likely has cardiogenic shock. They might have septic shock with a septic cardiomyopathy and concomitant ARDS. But either way, their lungs are extremely wet. The last thing you want to do is increase their extravascular lung water, unless you're looking to increase the patient's mortality. This patient either has ARDS or they have high left atrial pressures. Either way, if they're in shock and hypotensive, the move is towards vasopressors and inotropes. What if I told you that this was the patient's heart? Here's an apical 4-chamber of a failing heart. This patient has biventricular failure, extremely reduced LV systolic function. What's the first move here? Do we reach for fluids? Do we reach for the vasopressors? Do we reach for the inotropes or some combination thereof? I'll tell you the best way to increase this patient's mortality is to reach for the fluids first. Here's a nice example of a centrally directed mitral regurgitation jet. Please don't get hung up here and think this patient is in cardiogenic shock because of a primary problem with the mitral valve. This is secondary mitral regurgitation in somebody with a failing left ventricle. Fixing this valve is not going to fix the patient. Here's your next case. IVC on the left, representative image of the lungs on the right. What do we do? This one's a little more complicated. I'd probably like to look at this patient's heart before I made definitive decisions. But based on what we know, we can either choose a restriction or a test pathway. The reason a test pathway would be preferred, in my opinion, is the lungs are dry. If the lungs are dry, we have a free shot. And even if the filling pressures of the heart are quite high, we're unlikely to make any significant contributions to this patient's mortality with a small fluid bolus because they simply don't have any significant degree of extravascular lung water at the moment. Does this change your mind about a restrict or a test strategy for this particular patient? This is that patient from earlier in the lecture with severe pulmonary hypertension. Patients with severe pulmonary hypertension tend to do much better when they're kept dry. Often their pulmonologist will diurese them to the point where their hemoglobin is 17, 18, even 19. Contributing to this is the fact that these patients are essentially functional anaerobes at this point. But be that as it may, does this change your mind regarding the fluid restrict or a fluid test strategy? Given the constellation of findings with the lung ultrasound that we looked at earlier, and now this echocardiogram, I would be much more inclined to keep this patient into a restrict pathway. If it seems like I'm trending towards the excessively cautious side with fluids, that's because I am. A lot of people at this point in this lecture, which is about to wrap up, will begin to wonder, hey Mark, are fluids really that bad? Do I really need to keep my patients as dry as a desert, like it seems like you're advocating? The problem with that is fluid is only bad when it's in the lungs and when it causes tissue edema, which leads to microvascular dysfunction and organ ischemia. This is a retrospective analysis of the VAST trial by Boyd et al. Again, these curves were seen earlier in the lecture. A positive fluid balance, both early in resuscitation on the top and over 4 days, is associated with increased risk and mortality in septic shock. So here's the last case. This is a patient with 100% collapsible IVC. And if we remember the flow diagram from Lee et al. From earlier in the lecture, this is an extreme example of the hypovolemic phenotype. We should be able to get away with fluid resuscitating this patient and not really thinking that hard about it, or should we? These patients are among the most difficult in all of medicine to manage. Patients that are intravascularly depleted, who have increased extravascular lung water and increased tissue edema. What now? This is why it's important to look at the lungs in combination with the IVC, even when the IVC is 100% collapsible. This is a patient with severe pancreatitis and ARDS. They are third spacing like crazy, and right now they're intravascularly depleted with an excess of extravascular lung water. These patients are among the toughest patients in the entire hospital to manage. Essentially what we're trying to do here is fill up the vasculature to the best degree that we can without causing further compromise to the lung circulation. We want to optimize the ventilation settings with a lung protective strategy that's not going to induce any further barotrauma to the lungs, exacerbating the condition that already exists with excess extravascular lung water. And basically, we're going to hang on for dear life and hope that by causing no further harm, we're going to give this patient's body the best chance it can to heal from this tremendous insult. I hope that these cases illustrated some of the finer points in fluid management. Not everything is black and white. Not everything is one size fits all. It's best to use multiple modes of imaging and to also utilize echocardiography when it is appropriate. But anybody can learn lung ultrasound and IVC ultrasound in a relatively short period of time. And the best decisions when it comes to fluid resuscitation are to first do no harm. Assess your patients for the degree of extravascular lung water and use that as the foundation for your decision making when selecting the appropriate fluid resuscitation strategy for each of your critically ill patients. From there, incorporating echocardiography when it's appropriate is going to be your next best step. And when it comes to echo, most of the time we can get away with breaking it down simply by identifying whether the primary insult leading to increased extravascular lung water has to do with the right side, the left side, or the pericardium. Once we've developed competency in that realm, we can then take it to the final frontier of echo at the point of care, and that's looking for valvular catastrophes, which are often the underlying cause in your unexplained critically ill patient in the ED. Thanks so much for your time, and I look forward to scanning with each of you later today.